Perfect. تفضلي دكتورة. You were about to say something.
I just wanted to say that corneal transplantation and how to deal with it is a very important aspect of corneal transplantation, because it's not only about just transplanting a graft. It's about taking care of it to maintain as long as possible. So it's one of the topics that I was very happy to prepare, actually.
Yeah, thank you very much. And we know exactly who to choose when we want important topics.
Thank you very much. I'm so humbled by that. So shall I start?
Yes, we can. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Hello, everybody, wherever you are. And thank you for joining us in this very important session today of the Cornea series of Sinjab Academy Club. We are excited today to listen to Dr. Nancy Al Raqqad to teach us about saving a failing graft. As I mentioned in the post, that failure is not the end of the story. It might be a beginning of a success. So let us learn from Dr. Nancy how to convert a failure into a success. Thank you, Dr. Nancy. The stage is yours.
Thank you very much. So the topic of saving a failing graft, although the grafting started in 1906 by Dr. Zimmer, but the knowledge about how to take care of the cornea and how to get the best of results is still evolving. And I'm honored to be presenting this kind of presentation to talk about the latest ways and how we can ensure that our corneal transplant, they last as long as the patient's life or the corneal life lasts. And before we start about corneal transplantation, let's discuss why the cornea is a privileged site. You can see this is a crystal ball. And even if it's a crystal ball, it's a quartz ball, it has some artifacts in it. Unlike the cornea, that the normal natural cornea is just crystal clear, it is more than a crystal clear because of so many characteristics that has been embedded in it. Now, it's a privileged site because of the absence of vascularity, and we all know that. And we know that vascularity has, and this absence of vascularity, it hinders the delivery of immune elements. And also because of the absence of the lymphatics that prevent the delivery of antigens to the T cells in the lymph nodes. And also there's an expression of ligands that can induce apoptosis of stimulated T cells. So the cornea preserves its own clarity. And it has an unusually low expression of major histocompatibility complex antigens responsible for inflammation and a unique spectrum of immune modulatory factors in the cornea that inhibit T cell and complement activation. And all these are constituents of the very thin 0.5 millimeter corneal tissue that is responsible for most of our vision. Now, before we talk about corneal transplantation, it's very important to draw a line between a graft rejection and a primary graft failure. Now, a graft rejection is always a specific immunologic response to the donor corneal tissue. And a diagnosis of rejection should only be made if the graft had remained clear for 2 weeks after surgery and then problems started. While a primary graft failure is defined as a corneal edema that never clears from day one of transplantation, and usually it's due to technical errors. It's inherent deficiency in the donor graft itself, surgical trauma, or improperly stored or handled tissue. Usually, corneals are stored at usually not less than 2,000 cells. This is the ideal number, and it should be stored not more than 7 days if we use organ culture medium, or 14 days in Optizol. Now, the diagnosis should be done, made of rejection, as we said, if the graft was clear in the first postoperative period of 2 weeks. And the incidence of rejection is usually greatest in the first 1.5 years after rejection, but we do see rejections as long as 20 years after transplantation. There was a study that was conducted by Gilbert et al. That reported that the average rejection time of keratoplasty to rejection is 20 months. So we're talking about 2 years. So the peak of, we expect rejection, most of the cases in the first 2 years. And if I always tell my patients that the first 6 months of transplantation passed uneventfully, then you can just a little bit sit back and relax that they will not pass through an episode of rejection. But this does not mean that you have to close your eye on this. Now, what we are concerned about as ophthalmologists and cornea specialists is to prevent the progression from rejection to failure. Because failure occurs if we did not prevent the rejection, or if we stop it, or if we did not reverse it. So our duty is to stop the rejection when we spot it. Again, what causes a graft to fail? Either it's a rejection that is not reversed or an endothelial exhaustion. As time passes, if there is a manipulation inside the eye, a trauma, anything that can shed endothelium, this causes endothelial exhaustion. Now, let's talk about what causes failure in grafts. And it has different causes of failure according to the type of transplant. In the penetrating keratoplasty, usually it is immunologic allograft rejection. And this is the main cause in almost 29% of cases and in failures. Surface disease is responsible for 18% of cases, and endothelial decompensation without rejection. And what I mean with this is the shedding and losing of the endothelial density without an episode of endothelial rejection is responsible in 17% of cases. In cases of deep anterior lamellar, the failure is usually due to surface disease. Example, limbal stem cell deficiency, infectious keratitis, keratolysis, persistent epithelial defect. This is the main cause of failure. When we talk about DSEC and DMEC has almost no causes of rejection. Usually it is a graft failure from the beginning. And DMEC and DSEC, it is usually endothelial decompensation without rejection. This is the cause of failure. If you transplant a DSEC graft that has an inadequate population of endothelial cells. And if we reached a stage of graft failure, then the only solution for this case is, the only option is to change the graft. There's no mean of just trying different modalities of treatment when you have made the diagnosis of a graft failure. Let's talk about high risks for graft rejection, because we're talking about rejection. If it was not reversed, then we are facing failure. High risk of rejection, there's a long list of rejection, high risk rejection causes, and let me just spot the most common. Now, it depends on the type of the graft that we're doing and the patient logistics. If we have a preoperative inflammation, this is a high risk of rejection because the immune machinery is being switched on. And this means that you are dooming the cornea to fail. Corneal revascularization in more than 2 quadrants. If you have a young recipient age, and the younger the patient, the more the risk of rejection, because as we said, the immune machinery is turned on and it is more augmented than patients who are older in age. If anything that provides lymphatics and blood vessels to the eye and the cornea, like iris synechiae to the graft margin, this is also a cause of failure and rejection. Large graft, when it is more a proximity to the limbus, where it is more near the blood vessels, also poses a risk for rejection. And important is the inflammatory, if there is an inflammatory disease that switch on the machinery, autoimmune diseases also that are not controlled, and ocular surface disease like dry eye, cicatrization, and limbal stem cell deficiency are all causes of putting the graft under a high risk of rejection. Okay, what are the forms of rejection we talk about? A lot of us, they just classify the rejection as endothelial and epithelial and draw a line between these two as if they are separate from each other. Now, my message to you in this presentation is that although we can draw a clinical line between different types of rejection, but I would like to emphasize that what you act upon as if it is going to have an endothelial rejection. Because if you leave any detail in this episode of rejection, you will be, it's better not to be in agony of negligence, to just treat an epithelial rejection and pass it as a very simple episode. So epithelial rejection is a simple case of engorged limbal blood vessels where they exudate or transudate inflammatory materials across the graft recipient interface. It is taken by the epithelial, and these are lymphocytes, plasma cells, neutrophils, and they cause edema, and the characteristic edema of reverse staining. And what we mean by reverse staining is that when you put a dye on the surface of on the cornea, what you see is that the dye goes into the cysts, into the crypts between the cysts of the epithelial edema. And this is what characterizes an epithelial edema that is not of endothelial origin. So a reverse staining is the term that we say about epithelial rejection. And epithelial rejection is very important to remember that it can precede endothelial rejection by days or weeks. So you don't give the patient topical steroids or increase it or top it up and tell the patient to come after 1 month, because you are just giving the eye a chance to proceed to endothelial rejection that might want another kind of aggressive therapy. So it's very important, even if it's an epithelial rejection and you start on a low profile of treatment, to bring the patient in 1 or 2 days or just as soon as you can in order to make sure that the patient did not progress to endothelial rejection. Now, the other form of rejection is sub-epithelial or stroma rejection. And this occurs like adenoviral precipitates that we see in adenoviral keratitis. It is a deeper infiltrate that are caused by rejection of the stromal keratocytes, randomly distributed around the central cornea, and they can occur along any epithelial rejection line. It can proceed also endothelial graft rejection as early as 6 weeks or as late as 2 years after transplantation. So an episode of sub-epithelial infiltrates should not be passed also. It is very rare, and this is the good thing about it, that sub-epithelial rejection is rare compared to epithelial and endothelial rejection, but it happens. And if it happens, it might mean that if you leave the patient not treated well, he might go into endothelial rejection. And if he did not go, this means that you should keep an eye that this eye is going into a rejection episode sooner or later. Now, let's talk about the most common form of graft rejection, the rejection that nobody will underdiagnose, and that occurs in 50% of cases of rejection episodes. And endothelial rejection usually consists of lines of KPs, beginning usually inferiorly at the graft host junction, and they march up superiorly through the graft. Now, we see sometimes the caudado dust line, which is a hyperemic line separating the damaged endothelium from the undamaged endothelium. And usually the damaged endothelium is inferior to the line, not superior to it, because as we said, it marches superiorly and separates the healthy endothelium from the non-healthy endothelium. And the endothelium that has been damaged usually shows above it a stroma that is edematous, a hyperemic surrounding of the limbus, and sometimes you can see KPs. And if the vicinity is clear, you can see cells in the anterior chamber. And finally, a mixed rejection occurs in 30% of episodes. You can see the 3 forms: sub-etherial infiltrates, epithelial edema, stromal edema, KPs, and caudate dust line, all together in one case of rejection episode, severe rejection episode. Now, lamellar keratoplasty, although it manifests less rates or fewer rates of rejection, because we are giving the body less tissue to react upon. So the thinner the graft, the less the reaction of the body towards it. And that's why we say that a lamellar keratoplasty is usually superior to penetrating keratoplasty in terms of rejection rates, whether it is anterior lamellar or DALK, or whether it is posterior lamellar, DSEC or DMAC. The DALK usually can show some stromal immune rejection across its stroma, although not very common. In the DSEC group, we do have also endothelial rejection, but it is as low as 10% usually, and we see graft failure in 5% of cases. In case of DMAC, as we said, the risk of rejection is very low because we have only a descimate membrane, but the problems with the DMAC is the graft failure from the beginning. Now let's talk about clinically what you see. Before discussing what we see on the slit lamp, let's talk about what the patient comes with. I always tell my patients with whether they are transplanted penetrating keratoplasty, a DALK, a DSEC, any kind of transplant, is that the relationship between the doctor and the patient is lifelong. It's like a marriage with certain conditions, because the patient at any sign of abnormality, whether it is a photophobia, whether it is an abnormal, he woke up or she woke up with an abnormal feeling of that he cannot identify in the cornea, a funny feeling in the eye, a vision that's not as clear as last night. We don't have to go into hyperemia and severe photophobia and decrease in vision in order to go to your doctor. It's very important to maintain as early as possible walk-in to these patients as they have anything that has deviated from the normal vision or the normal state they have. So any prick, although it is not significant, any prick, any abnormal sign, any not feeling well feeling is a reason that why they should go into a cornea clinic. And if not, into any emergency situation and clinic, and contact your treating physician or ophthalmologist. So once we put the patient on the slit lamp, we see and these are from the most common to the least common signs: corneal edema. Of course, if it is endothelial rejection, we see stromal edema, epithelial edema in cases of epithelial rejection. The most common then is keratitic precipitous, KPs on the corneal graft, but we don't see it on the host. Corneal neovascularization, as vessels start to hit the cornea that is inflamed. Stroman infiltrates. I always say that vascularization around the cornea is a very good sign in infection, which means that healing is on the way. And it's a very bad sign in corneal transplantation. It means rejection is on the way. So these are contradicting feelings towards the same clinical situation. So a vessel encroaching in the cornea in infection is a good sign of relief. A vessel encroaching in the cornea in a transplant is a sign to panic. The fourth sign is a stromal infiltrate, a dust line. As we said, it's a line separating the damaged endothelium from the undamaged endothelium. An epithelial rejection line that occurs also on the epithelium once there is rejection, and sub-epithelial infiltrates that are less commonly seen in cases of stromal rejection. Now, the diagnosis of immunologic graft rejection or graft failure is made if the signs of rejection were not treated and cleared after 2 months of treatment. So if you have an episode of rejection that was very bad and you bombarded it with all the treatment options that can be used, and after 2 months of treatment, you could not go back to the state it used to be, then you can announce the white flag with the diagnosis of a graft failure. Before that, just give the eye the time to recover and the patient the time to recover and give it 2 months of a window in order to go back to pre-rejection state. Now, let's talk about management. How do we manage a graft that is going into rejection? Before we go into being safe is better than sorry. So before panicking about the situation, let's not go into a panicky situation from the beginning. So we avoid the risky situation before we graft. It's very important and mandatory to maintain an ideal vicinity, an ideal environment where we are putting our graft in. It's very important first to manage the surface, address any dryness, treat any infection, whether it is a surface infection, marginal keratitis, blepharitis, anything that might invite microorganisms to the surface. A hepatic eye disease, whether it's a surface or stromal, is very important to make sure you control it before you open up the eye and graft a cornea. It's very important to take care of the vicinity, which means the surrounding. Take a look about the stem cells. Are they enough to maintain clarity of the new cornea? If not, do transplant stem cells. Use, if not from the other eye, use a keratolimbal allograft or simple limbal slit stem cells in order to revive the palisades of Vogt cells that are capable of maintaining the cornea that is transplanted in very healthy state. If there are vessels, it's very important to make sure that the vessels are treated before you attempt a graft. In the past, it used to be a protocol of just aborting a process of corneal transplantation if the cornea is just vascularized. And this is not the case anymore, because we can do something about these vessels. We can use subconjunctival injections of anti-VEGF, of Avastin, or Lucentis subconjunctival injections in order to ameliorate the vessels around the cornea. Given that the reason why the vessels are there, let's say it's a limber stem cell deficiency, is treated. You just don't stop a vessel or tie it or cauterize it or just block the lumen and keep the initial pathology going on. So if there's a viral infection with herpes, you have to treat it. If there's an ongoing infection or inflammation, it has to be treated and addressed before we go into tying off these vessels that are bombarding the cornea. Once we reach a stage where the vessels are reversed and blocked, then we can proceed to transplantation. And needless to say that the systemic disease, whether it is rheumatoid arthritis, any cause of peripheral ulcerative keratitis, OCP, Stevens Johnson, any disease that is causing an aggressive immunological response on the cornea should be treated first, maintained, and at a very stable level before you attempt to transplant the eye, because then melting and failure of the graft is something you cannot avoid. So do not transplant an inflamed eye, even if it was the worst case scenario you see, because then you are dooming the eye or the transplant with failure. You have to treat the vicinity, treat the eye with, even if the eye is perforated, try to, if it is a small perforation, just put a contact lens, sometimes glue it, although if it is inflamed, glue does not do a good job. You can just put a contact lens and give some aqueous suppressants to decrease the influx through the perforation until the eye is quiet, and you treat you make sure that you control the inflammatory response of the body, and then after some time you can transplant it. Otherwise, you can put a tectonic graft in place, and just to make sure, knowing that it might fail and melt, but it's just to give to buy some time in order to control the inflammatory machinery that is switched on in the patient. So once you have an ideal environment, then you go ahead and you transplant. It's very important what instructions you give to the patients. As I said, you avoid large grafts, especially coming towards the limbus, especially in patients who have the cause of transplant is infection, because you don't want to go near the limbus and the lymphatics and the blood vessels. Try to go to a smaller graft, and you have to keep an eye on the sutures. And I always say sutures, loose or cut sutures are a cause of vascularization or rejection. So you never leave a cut or loose suture in an eye or a graft that has been transplanted. Even if it is the first or second week post-transplant, you have to replace it or change it. It's very important also to control your medications. Whenever you can, it's vital and mandatory to prolong the life of the cornea is to use preservative-free drops, because then you are maintaining a healthy epithelial surface and decreasing the sensitivity of the cornea to the preservative material in the drops. It's very important to control the intraocular pressure, because if this goes out of control and you have to start the anti-glaucoma medication, then you might lose control at some time and the surface would be so degraded. And I am one of the defenders of the steroid use, especially in young patients in cases of corneal transplants, aggressive use of topical steroids in the first 6 months post-op, because it affects the survival of the graft in a high percentage. And it is very important to maintain a lifelong use of these steroid drops, if it is possible, if the patient did not develop anything else like a glaucoma, or he was a steroid responder, or there were complications related to these steroid drops. So a patient comes to your clinic and you know this patient for like 3 years and he has this red eye and some tearing, and you examine him on the slit lamp and you see signs of endothelial rejection. Now, the management of corneal graft rejection consists of the early detection and aggressive therapy with corticosteroids. So regardless of any treatment method that is emerging on the surface, corticosteroids, topical and systemic, are the mainstay of treatment in any graft that is showing signs of rejection. So it is vital to treat what triggered a rejection. So if the patient had a history of herpetic keratitis, this might recur in the transplanted cornea. So you treat the infection and you bombard the rejection. If there's a loose stitch, you remove it. If there's an infection, you treat it. If there's a flare-up of systemic disease, you just control it. And you liaise with the medical specialties. Meanwhile, we address the rejection, and the rejection is addressed with the immunosuppressants, which is in our case, the corticosteroids. Now, addition of immunosuppressive therapy, which I see all the time around me, it helps to, as an adjunct treatment to the corticosteroids, but it does not replace it, which means I cannot give my patients cyclosporin orally or topically and keep the Pred Forte drops twice a day and pray for God that the cornea will survive. This is not the way we take it. Steroids is the mainstay of treatment, whether it is topical or systemic. And we will talk about what protocol we give. And then if you want a speedy recovery, especially in cases which are resistant, like in the cases of young children, they are the most to resist and to reject. In cases of a patient who has a systemic disease like rheumatoid arthritis. And as we said, the immune response is augmented, and we need to just put control and switch off this immune machinery. We supplement our treatment with other immune suppressive therapy, but they do not replace the corticosteroid role in controlling or curbing the inflammation and the rejection associated with corneal grafts. Topical steroids are the primary treatment for acute rejection with epithelial rejection, as we said, but we have to keep an eye. If we started to see any sign of endothelial rejection, systemic steroid should come to the rescue. As we said, supplement treatment is possible with cyclosporin and tacrolimus. And also something that I use a lot in my clinic and in my practice is the use of anti-VEGF treatment, which is a sequential subconjunctival injections of Avastin anti-VEGF or Lucentis, although off-label Avastin, but sometimes I use Lucentis to give 0.01 cc. It's the same dose that we give intravitreally, and I give it to a large carriable vessel. So if I see a diffuse vascularization, this is not something I worry a lot about, because once I treat it with steroids, once I treat the offending agent, these vessels just disintegrate. But in cases of infection, let's say when you see a large feeding vessel that is arborizing into 3-4 other vessels hitting the cornea, it's very important to stop this vessel from continuing its transudation and exudation. And anti-VEGF treatment has proved its efficacy in clinical use. And sometimes you might need to give up to 3 or 4 doses of subconjunctival anti-VEGF treatment, spaced between 1 month to 3 months apart. And actually, the nice thing about it is that when you bring the patient to his follow-up clinic, hello? You still hear me? Okay. When you bring the patient to his follow-up, you can see that the RBCs stagnated in the first follow-up visit, and then in the second follow-up visit, you can see that the blood vessels has become weathered, blocked, and it becomes a ghost vessel, which means that your treatment is doing its job nicely. Now, in children, it's very important to make sure you do not cause a systemic absorption. So the dose in children is half the adult dose when you give subconjunctival injection and of Avastin or Lucentis, and to avoid complications like sometimes necrosis or of some blood vessels, sometimes femoral head of femoral bone necrosis. It is reported in subconjunctival injection with systemic absorption. So in children, I give half the dose, and I treat it as the adults. with other topical and systemic drugs. So how do we give the systemic corticosteroids? There are a lot of schools. There are different schools and different practices which give systemic corticosteroids to failing grafts. Now, the one that I have learned and the one that I practice and the one is working for all my patients is when I spot a patient with a rejection, and I had a patient who rejected her siblings' graft. I transplanted her siblings, her sister who died. She took the graft of her sister. So we're talking about a lot of compatibility in this case. And she rejected the graft 10 times. And after the 10th time, she's been rejection-free now for 4 years with a crystal clear graft. So as long as you do what you do and it's doing a good job, don't change it. You only change when you have contradicting results with whatever you do. And that's the reason why you just start to practice something in a different way. So what I do, I admit the patient to give him or her pulsed methylprednisolone. In the literature, it is described in the American school as 500 milligram of methylprednisolone. I give 1,000 milligram of methylprednisolone over half an hour in 200 cc normal saline, and the patient relaxes, and I just give it over half an hour with taking after 4 hours the vital signs, and I supplement the patient with topical steroids hourly. I give sometimes, if there is an infection or flare-up of any infection, I give antibiotic eye drops. I give anti-glaucoma medication, especially timolol, because it is friendly to the cornea, which is a beta blocker. And of course, you protect the stomach with some proton pump inhibitors like famotidine once the patient is admitted. Now, I don't have to see the patient for 3 days. So I admit the patient for 3 days. I just make sure that the ward, make sure that the patient vital signs are under control. I don't have to see the patient on the 3rd day. The 3rd day, I discharge the patient. I see him on the 4th day. And almost every time the patient comes on the 4th day, the rejection is reversed. Once you spot it early, you treat it aggressively, you reverse the rejection. Now, if this is not possible, because there's no possibility of monitoring the vital signs, if the patient cannot take the methylprednisolone, if there's a contraindication of the systemic methylprednisolone for any reason, let's say that the patient has osteoporosis, or there is a problem that you cannot give the patient, or diabetic, and the diabetic control went just out of control when you give the first dose of methylprednisolone, it's possible to switch to the less effective method, which is oral prednisolone daily on a single dose, 40 to 80 milligram of oral prednisolone, again, with all the topical and the proton pump inhibitor supplementation that you give. And you see the patient, you give the patient the 40 to 80 milligram over longer time than the pulse therapy of 3 days, and you watch for weathering of the signs of rejection. Now, it's very important to control, as we said, the blood sugar. It's very important to control the vital signs, and it is very important to control the intraocular pressure by adding some beta blocker or any pressure controlling drop to the treatment. Now, one of the questions that I've been asked is that if you have a patient with a rejection and you admit him with IV methylprednisolone, do you discharge him on oral prednisolone? The answer is not. I do not, and I do not need to. He takes oral prednisolone as a treatment for a longer time if you cannot afford, or the patient cannot take the pulse therapy. And you take it up to, I give it just up to 2 weeks. If there's no sign of improvement, I start bombarding in additional supplemental therapy like cyclosporin, tacrolimus, or systemic cyclosporin. But if I admitted the patient for IV methylprednisolone systemic, it's just IV methylprednisolone. I do not have to discharge him on oral methylprednisolone or oral prednisolone. Now, what other treatment modalities? Other treatment modalities that are, as we said, supplementary, they are not substitutive to corticosteroids, is the cyclosporin, the calcineurin inhibitors, and the tacrolimus. Okay, and they are viable options, and these are especially useful in cases that you are going to transplant the cornea, that is high risk, and to give it as before surgery to prevent or to shut down the immune system a little bit as you transplant the cornea, and to give it for a short time after transplantation. Its efficacy after a long time of transplantation, when there is an acute rejection, is controversial, and I do not use it a lot in my practice. I rarely use cyclosporin topically for patients with rejection, unless it is a planned transplantation with a high risk already, like a vascularized cornea that I have no way except transplanting it, or a child that I do not want to put through the aspect of rejection, and I know that might reject quite often, so I use topical cyclosporin. Or if there's a patient who is one eye patient with a graft that is a redo graft, because we know every time we introduce a second or a third or a fourth graft, the chances of survival with the graft just go down. So if the first graft has a survival rate of 95%, the second has 80, the third is 70, because we are just testing the immune response of the body as we graft the more corneas. So in these cases, I do not substitute the cyclosporin 0.05% twice daily to the regimen of corticosteroids. Tacrolimus also it's not available actually in Jordan for ophthalmic use, but it can be brought from countries around us. And it is possible to give it systemically also. And as I said, it is not, it is an adjunct. It's a supplementary treatment. It is not a substitute. And sometimes the tacrolimus, especially I use it in cases of adult keratoconjunctivitis or the vernal catarrh that you see in the adults, which is the very aggressive one that keep resisting corneal transplantation. And these patients usually are young adults with a severe case of vernal catarrh that you need to control their disease. And this is where sometimes I import and order tacrolimus to be used at the same time as the transplant to save the eye from the severely inflamed response once a graft has been transplanted. There's also a study to support my observation with my patient when they saw that used 0.03% of tacrolimus were effective in preventing irreversible rejection with high risk. So you use it with the patients that has a high risk of rejection rather than wait for rejection to start in order to use it. Systemic administration of oral tacrolimus between 2 and 12 milligram daily is also beneficial in preventing and treating graft rejection in high-risk patients. It's very important if you use oral cyclosporine at a dose of between 50 to 100 milligram daily. It has a preparation of 25 and 50 milligram and 100 to monitor renal function and kidney function of the patient, and to make sure that serial investigation are being performed. And I end my talk with saying that I saw just 2 days ago that it takes considerable knowledge just to realize the extent of your own ignorance. And the more we learn about our practice, the more we realize how much we were ignorant sometimes with our patients. And I hope nobody is ignorant anymore. Thank you.
Thank you very much.
I cannot hear you, Doctor. I cannot hear you, Dr. Martin.
Yeah.
Again.
Can you hear me now? Hello?
Yeah. Yes, I can hear you.
Yeah, great. Now, I'd like to thank you, Dr. Nancy, for this comprehensive approach and nice presentation, which addresses all points direct to the point and in a simple way. And you gave us just like a fast food meal that we can use it in our daily practice. And of course, we need to rewatch the video again and again because it's full of very helpful information. Thank you very much, Dr. Nancy. And I would like to welcome Dr. Ubaida Kilani as well in the panel to initiate a nice discussion.
Thank you very much, Dr. Nancy, for the introduction. Dr. Nancy, first, genuinely would like to congratulate to you for a comprehensive talk. Hugely informative and very, very thorough. In my mind, I had a couple of questions that I just wanted to pick up on, if possible. I noticed the intrastromal Avastin, the use of intrastromal Avastin, and its effect on reducing corneal neovascularization. Now, I find that using anti-VEGFs in cases that I do pressure flow microshunts, even trabs, as adjuncts, the blebs that happen after a week look absolutely beautiful, very diffuse, with no angry vessels. I'm interested to hear, you do it intrastromally, 0.2 mLs. Could you just talk us through that a little bit more in detail?
Yeah, I agree. Anti-VEGFs are just, sometimes they do wonder to the corneal vicinity. I do it subconjunctivally and intrastromally. So if I find that there's a deep pore vessel that I cannot reach by giving a subconjunctival injection, I do go under the microscope with a 29 or 30 gauge needle and just give it just around under the, I don't give it in the lumen directly, I just go around it. In the stroma, I just identify it. Sometimes I go under it, underneath, and just inject. Of course, intrastromally, 0.2 or 0.1 cannot be injected. The stroma is very resistant. So I just give a little bit, like part of whatever can go without resistance in the vicinity. And I don't push because sometimes it's very dangerous if you push the anti-VEGF treatment inside a lumen of a vessel, or you push it largely because sometimes you can make it go to the inadvertently to the trabecular meshwork, and sometimes you can see it shooting out like an air bubble if given in the wrong way or aggressively. So you have to be very careful and subtle. And as you said, you see the blanching immediately. And then the effect of it, just if you follow the patient up, you can see the disintegration of the vessel, the blood, the blockage, you can see them just coming slower and fewer and more apart. And this is very nice to see because you can see under the slit lamp all the effect of your treatment. And this makes you just convince the patient of it. The subconjunctival is more forgiving because it is subconjunctival. It can be used along with cauterization, although I do not use cauterization a lot except in persistent cases, but I do use it in large caliber vessels, and I give the 0.01 ml of anti-VEGF treatment. Sometimes I give in multiple areas or quadrants to make sure that just the vessels that just disappear. And as you said, they look, the eye looks whiter, the vessels blanchier, and just gives me confidence to proceed. Thank you for the question.
Absolutely agree. Now, we're going to take it to a slightly different level. For the residents in the audience, often a challenge is picking up rejection early and treating it correctly, as you said, with topical steroids being the mainstay of treatment. Now, how can a resident destroy the fear of a recurrence of a post-herpetic, a graft that you've done, and then a resident comes and then splashes them with steroids, and it's herpetic etiology? How can a resident differentiate between both? What would be your take-home key pearls to give to such residents to differentiate between a rejection and a recurrence?
Yeah, this is a very important question, actually. So I always teach the patient and teach the team, the residents, whoever is in charge of my patients or any patients in the hospital or ward, is that a patient who has a graft is an emergency. So you can, if a junior doctor sees him and cannot diagnose what's wrong with them, call a senior resident. If the senior resident fails at spotting it, just call the consultant on call me. I have an open channel with my residents and fellows when it comes to patients with corneal transplantation. We are in an area of very sparse and very, very poor supply of corneal tissue. So this is a treasure we have to just maintain to keep. So As I said, being safe better than sorry. I always tell them, call me at the middle of the night to tell me there's something wrong with your graft, a patient you grafted, and I come and discover it's nothing. It's better to me than keeping me asleep all night long and discovering next day that he has passed an episode of severe graft failure or rejection, and we could not treat that. So I'm okay with a phone ring at 2 a.m. in the morning about panicking about the graft. So they have this relaxed kind of attitude of just addressing a corneal graft, and they know when to talk to me. And I always say it's very important when they come and bring in the patient to hit and to elicit the signs, because it's very important to look, as we said, the signs of rejection is something that's abnormal that happened to the patient. So listen to the patient first. Anything that deviated from what he used to have is an alarming sign. Even if he woke up with a funny kind of vision, is an alarming sign. Because this is what makes you a good doctor who catches evil before it happens, or a bad doctor who just leaves the evil to prevail, and then you treat the very bad sequelae. So picking up on these very early signs makes you a very good and talented doctor. So listen to the patient, take things seriously. Treat anything as rejection, because as I said, rejection means admission of the patient and giving IV methylprednisone if it is an endothelial rejection. If you see edema, if you suspect this is a high OOP with edema or an episode of rejection, no, come and bring the patient as a rejection. Be wrong with that, but don't miss a rejection. And then we decide on whether it is a high episode of elevated intraocular pressure or rejection. Now it comes to infection. So patients with herpetic keratitis are a special kind of category. These patients, I keep them on oral acyclovir for the first year after transplantation. And I educate the patients first, because the patient will come and say, oh, I missed my dose for a month of my oral acyclovir, or I felt funny like I used to feel before I did the surgery. I feel the virus is coming to me again. And the patient is always right when he says it. So again, I say, listen to the patient. Patients with herpetic keratitis are half doctors in my clinic. They know when to increase the dose. They know when to taper it. They know when an episode of herpetic reactivation occurs, and they come to me, oh, I had just a funny feeling last week and I just increased the dose twice. And once everything is fine, I came to my appointment. And we're having this kind of relaxed kind of way of looking at it, because at a certain point, they come to know and realize how this virus acts and just be confident of themselves. And sometimes they just spot my and say, oh, this resident just missed the herpetic keratitis, and that one knew what I was talking about. Sometimes they come and they spot the doctor who just realized what the problem was or not. So education is very important. Listening to the patient is very important. And as I said, if it is herpetic keratitis and you suspect it, it's okay to just supplement the patient with oral acyclovir, because usually it's a stromal. Reactivation is usually a stromal keratitis. It does not come usually as epithelial. If you see an epithelial, it is an epithelial. It is a dendrite. I think if you miss a dendrite, then this should be a fundamental kind of question rather than a rejection. So we should go back to real one. Okay, so if you miss a dendritic herpetic keratitis. Thank you for this. Is a very important question, actually.
Perfect. I think we've spurred some interest from Tirtag Abdul Ghani, who said, if you have a case of graft rejection, again post-herpetic keratitis, within the first year, do you keep them on topical and systemic steroids? And what's the treatment in these cases? I think you've answered that question by if they've ceased oral acyclovir, we restart it. And what dose do you use for acyclovir? Is it sort of how much do you tend to use? Is it 400 twice or?
Yes, now the 400 twice is for the maintenance dose, usually perioperative, which is few days before surgery and few days after surgery. I just bombard with half Zooster dose. I just elevate the level of the acyclovir in the blood, which means like 400 4 times or 405 times. This is in the perioperative, which means 3 days before, a week after, just to to overcome the stress of the surgical procedure and all the high risk of flare up. And after that, when I feel that everything is fine, because I'm giving the patient steroids now, usually I give hourly steroids post-operatively, but in cases of herpetic keratitis, I just do not give that frequent. I just give it 6 times a day for the first week, balancing with the use of acyclovir. And then I just taper it quickly to 4 times after 1 week, and then for a few months. But I just keep a balance between the acyclovir. After one week or 10 days, I just go down to twice daily for 1 year. But usually my patients, if they have an episode of flare-up, I just top it up 4 times daily. So we just work on the acyclovir dose.
Thank you so much. Over to you, Dr. Mazen. I think Dr. Nancy we've given her a hard time, and she's answered in outstanding fashion. So there are a few other questions in the Q&A, but I think it's all quite similar in terms of responses, and we've covered most of them within the talk. But over to you. You're the big boss here.
Oh, thank you very much. Actually, your discussion was amazing. Thank you. Now, how to treat a graft rejection due to infective keratitis or infectious keratitis? So infection over the graft, how to treat it?
So a graft has been transplanted. There's an infection in the graft causing a rejection. This is it. This is how.
Yeah, this is what they mean.
Actually, priority should be given to the infection, of course. So we abstain from the topical steroids because they will affect the microorganism who's causing the infection. And it's very important to target the infection with the antimicrobial that is proper to the eye until we see signs of healing. And I said, vascularization in cases of infection is a very good sign. This means that you can just sit back a little bit and relax, that your treatment is doing its job. Although it's not a very good sign in cases of rejection, but once you start seeing that the patient is healing and going into scarring, you start introducing the steroids again. I do not give systemic steroids in a patient who has an aggressive infective keratitis at all, even systemic, because this will affect it will cause immune suppression of the body, because this is working against each other. I want to increase the immune machinery to fight the infection, and after the infection is gone, then suppress the immunity in order to survive the graft. So infection goes first and then rejection. Most of the time, if it leaves a very faint opacity, it's all right. It might affect vision a little bit, but does not cause me to re-graft. Unless it has left a very severe opaque cornea, then this is a reason to regraft again. But I don't regraft before 6 months of having the eye quiet.
Fantastic. Now, I would like to have take the opportunity. Yes, Dr. Nancy, I'd like to take the opportunity to ask you both a question, which is very common, because Dr. Ubaida is a glaucoma specialist working in the UK, and you are, Dr. Nancy, you are a cornea specialist. So let's assume that a patient has Ahmed valve because of glaucoma. Can you hear me?
I just need to plug my power supply, and otherwise I will not see you in 2 minutes. Just a minute.
Okay. So, Dr. Ubaida, I will ask the question in 2 different ways. The first way is a patient with Ahmed valve already has Ahmed or any of the valves, and the patient needs corneal graft. How to prepare the patient, what precautions we have to do, how the follow-up would be after the operation. And then I will ask in another way, that we have a grafted patient now, and because of glaucoma, we need to implant a valve. So what precautions, how to deal with this situation? So let us start with scenario number 1. Already there is an implant in the eye or a valve in the eye because of glaucoma, and the patient needs corneal graft. Okay.
So it's a very, very interesting scenario, and it's one of the times where often cornea guys and glaucoma guys clash. They're always shouting at us, "Why did you make such a long tube in the eye? You know, next time trim it shorter." So that's also a very, very important consideration. Not only with established aqueous shunts that are large bore, like the Amit glaucoma valve, the Barvelt valve, but also with the newer devices. It's important to make sure that when placement initially happens, it's either in the mid AC or a third close to the iris and 2/3 away from the cornea. The reason being because the eye isn't always going to look like it is when the patient is supine, lying down on the bed, especially in patients who are atopic. I saw an MRI recently, a live MRI of a patient who's rubbing their eye, an ophthalmologist rubbing their eye. The amount of distortion and displacement of not only the cornea, but the entire globe is just unreal. So if you imagine a plastic tube, and if any of you have held a glaucoma valve or a baba, it's rigid stuff. If it's going to be endothelium versus tube's going to win. So we always have to keep this consideration very much in mind. If you don't get the tube placed in decently close to the iris, obviously not embedded into the iris, but close to the iris, then don't leave it in there. Remember, it's a foreign object in the eye that's going to stay there ideally for the next 20, 30 years, hopefully going to continue working without failure. So that's point number one. If in the unfortunate event that you end up with endothelial compromise as a result of a foreign device in the eye, our priority becomes whatever the cornea guys want. If they feel that that it's too close, then a combined approach when it comes to cornea grafting and tube shortening can happen, or even replacement if need be, because the visual preservation is going to be our goal here. Because even if Dr. Nancy does another DSEC or DMEC or whatever needs doing, then it's only going to be a matter of time again where we're going to be compromising valuable corneal tissue. Corneal tissue is not just a luxury just in Jordan and the Middle East. It's becoming a worldwide problem. And organ donation is something that we also need to discuss and increase awareness of across the Muslim and Arab world. And there are various ethics that we could probably discuss in another forum. But tissue is very, very valuable. A tube you can take out, but endothelial cells, they are, as you know, we count them by the one. So that's what I would say, is that we would be certainly guided by what they say. If they say, look, this has happened once, it's going to happen again, either we need to tie this off or recite it a bit more posteriorly, then that needs to be a consideration, or simultaneous tube shortening, either ab internal, which is certainly possible with micro scissors and micro forceps. VR instruments, we use those very, very much, particularly when it comes to angle surgery. And that's what I would say is certainly a big, big consideration. Over to you, Dr. Nancy. That's what I think from my side.
No, thank you very much. You're a very good advocate of the cornea, actually. Thank you. One thing I want to add is recently our colleagues have adopted an approach of a posterior to the iris, especially if we have a pseudophakic patient. If the patient is pseudophakic and there's a PCIOL, they put the tube insertion just posterior to the iris, so we wouldn't just worry about the cornea touching or the patient, as you said, lying supine, or sometimes in shallow ACs. It's very, very important, and it's actually a nightmare. So if the patient is pseudophakic, or if you are planning to take out the cataract, just take it at a very early time, because this will facilitate the tube function being put behind the iris. Now, if it is phakic, then this cannot be done, because just the tube touching the lens would just cause a cataract. So as you said, it's a very reasonable way of looking at things. It's a balance between what is precious and what is more precious. Precious, sir.
Precious, sir.
And it's always a collaboration Pressure, so yeah, this is just a joke. So it's always a collaboration between teams in order to bring the best towards the patient's benefits, actually.
Definitely, and on that point, sorry, Dr. Mazen, Professor Mazen, both sulco tubes and pars plana tubes do happen. We do them. The issue is that in the vast majority of cases, correct placement and not, going straight through the zonules, or if the patient's not vitrectomized in the pars plana cases, is not as common, certainly, as AC placement. Training is another issue. I would say as a proportion of AC tubes that I've put in compared to sulco and pars plana tubes, it's probably 95 to 5% wise. But yeah, I do think that it's certainly a feasible suggestion. In the vast majority of cases, you'll find that AC tubes are far more popular. But yeah, it's certainly an important consideration to think about, at least in patients who you're thinking about either grafting or have been grafted and have resulted and need to be on maintenance dose of steroids requiring surgical intervention. Certainly something that I think we all should be thinking about.
Yeah, fantastic. Now let's assume that the patient doesn't need a valve. The patient needs, for example, a trab. So do we do the trab first or the keratoplasty first, or we can do both in the same session?
So okay, that's interesting. We're talking full thickness.
Actually, I wouldn't go with the glaucoma people doing the trap at the same time with the PK. I wouldn't.
Yeah.
Some politics going on.
Let them do the job. Worry about hypothesis, for example. Do all this, the nightmare, and pass it through. And then when the eye is okay and controlled, I do the grafting. So.
Yeah, I mean,
other way around. So yeah, I wouldn't go with them.
With me, what I find is I like to be the eye untouched for a minimum of 9 to 12 months. I've been doing this long enough to know, and been bitten in cases where, okay, I can see that the patients either had a trab or whatever, and they've been on steroids for a long time. They've developed a steroid posterior subcapsular cataract or whatever it is, or a cortical cataract, and they're visually, it's just declining. I can see in front of me, and it's not glaucomatous decline. The pattern deviation is fine. And I said, okay, no, let me make the patient happy, and I'll do his cataract. I'll put an eye stent in at the same time. And what ends up happening is that the PRESERFLO or tube fails. Even if they're on intense topical or in some cases, particularly, uvetics or whatever, oral steroids. So in such patients like you like to keep the eye quiet, non-inflamed for 6 months. I actually, when it comes to after anyone's touched the eye or gone into the AC, to leave the eye for a minimum of 9 to 12 months. Even this is in sort of lab-based studies, on fluorometry studies, you can see there's subclinical inflammation and inflammatory mediators in the anterior chamber aqueous samples, even at 9 to 12 months. And it's backed up by evidence that leaving a latent period between at least cataract surgery and any incisional filtration surgery of at least 9 to 12 months is important.
Okay.
So no, not at the same time.
MashaAllah. I think your kid has an opinion as well. We can listen to him.
It's not only moms. I like to see this image. I'm not only the one interrupted by my children. God bless. Yeah, I do agree. I let the glaucoma people just do their job and do whatever makes them comfortable, and then I do the cornea transplant. Absolutely.
Okay, fantastic. That's fantastic. Actually, I think no more questions, and it has been a very nice discussion, especially with the two subspecialties together. I love this kind of webinars to have a topic to be discussed from more than one point of view. So really, thank you very much, both of you, for Dr. Nancy, of course, for the presentation, and Dr. Ubaida for the discussion, and and to the audience as well for being with us.
Dr. Mazen, yes. I just want to say I tuned in because I knew it was Dr. Nancy Al Raqqad, and then all of a sudden it says the host has decided to add you on as a panelist. So I had no previous warning. So forgive me if I'm dressed in home clothes and not in a suit. You guys deserve the, And then I asked my wife, do I look okay? She said, you look fantastic. Don't worry, just go. So thank you very much. Welcome. It's been a fantastic discussion, and thank you for the kind invitation and the fantastic talk, Dr. Nancy. Really, it was very informative.
But unfortunately,
I enjoyed this talk.
Yeah, unfortunately, nothing to do with topography. So this is why I keep quiet.
You're the master of topography.
Okay, so
we can talk and just thank you, Dr. Mazen.
Thank you very much, everybody, and have a good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Assalamu alaikum wa rahmatullahi wa barakatuh.